somewhere else. Diagnose fungus, they remove the fungus and it comes back again. So we are not actually treating the medical disease medically. It's a medical disease. Surgery has a role to remove all this inflammatory load and give access to the topical solutions which are required. So, and see now, if it comes to the surgery, even the surgery is not a complete surgery. A lot of septations are left behind everywhere. See, and this time the disease has, because of the mass effect, has broken the inferior wall of the frontal sinus to have entered into the orbit, and that's why this patient is a proptosis. Now, this fungus is a non-invasive fungus for sure, and this always, as it is destroying the sinus wall and entering into the orbit, it gives a suspicion of an invasive fungus. Differentiating invasive from non-invasive fungus by radiology is, if you ask me, is very simple. Any fungus which is occupying mainly the sinuses, see, the entire sinuses are full of disease. At one point it is destroying the boundaries and going beyond the sinuses. This cannot be invasive. This is non-invasive fungus. This is because of the pressure and the previous surgery. What could be the picture in the invasive fungus? Invasive fungus would have been limited to one of the sinuses with less intrasinus component, some wall destruction and more extrasinus component. What my point? This is the basic difference. You don't need to go in the depth.
How to recognize earliest time? Earliest, how to recognize?
Earliest you will find the sinus, intrasinus component is very less.
Unequivocally, paper says that most of these invasive aspergillosis present at the article apex and at the indus.
These are the common sites where they invade. It doesn't mean that all patients are going to be there. Like, for example, the disease within the maxillary sinus, eroding one of the wall of the maxillary sinus and enlarging in the infratemporal fossa, and that extra sinus component is bigger than the intrasinus component with a wall destruction at the site of attachment. That's my point. But any fungal disease which is completely occupying the sinuses are full of disease with a little bit of extra sinus extension, is because of, this is non-invasive because of the expansion erosion or previous surgical treatment. Primarily an invasive fungus will have minimal intrasinus component and maximal extrasinus. This is the basic. Secondly, to diagnose further, MRI is the answer for most of the head and neck diseases. I tell you now that time has changed. Radiological advancement has gone to the highest level now. CT scan has a limited value wherever we want any details of bone, like in the temporal bone or in the PNS where the CT is most useful, because we want the bony anatomy. Mostly we have to work in the bony confines, like in the temporal bone and the PNS. Rest everywhere in the head and neck, MRI is the answer. MRI has amazing versatility. You have n number of sequences which help you to differentiate between the lesions. Like you have T1, contrast, T2, then you have variety of sequences, diffusion weighted, you have this fiesta sequences, you have n number of sequences by means of you can see, differentiate the lesion into actually what it is. CT scan cannot differentiate much. Even for the fungus, if you want to confirm pre-operatively whether it is a fungal disease or not, MRI is the answer. You will see a lesion which is having a mild to moderate or whatever hyperintensity. You have absolute black halo or huge hypodensity on T2. That is classical fungus. So MRI is amazing tool for anything. Like for PNS tumor, now our choice of investigation is MRI. Not only that, where it is extending, if it is going beyond the confines of the sinuses, But MRI can actually reliably differentiate by means of diffusion weighted imaging whether it is a benign or malignant. Diffusion weighted imaging is basically done between the two magnets to see the water proton diffusion in the tumor. Tumor which is highly cellular, like malignant tumor, having more nuclear cytoplasmic ratio will have less diffusion. Tumor like benign tumor or inflammatory condition with more water content will have more diffusion of water content. So on diffusion weighted you can calculate the ADC values whether it is a malignant tumor or not, and more than 90% of the time you can reliably differentiate whether it is a benign or a malignant tumor or an inflammatory condition. Like the last week I gave you an example. You got a patient who has been having the facial palsy, had a huge parapharyngeal temporal bone mass lesion on CT scan. He had a CT scan. He was diabetic also, facial palsy. Then he developed multiple cranial nerve palsy. Had a huge mass lesion in the parapharyngeal space and a bulge in the nasopharynx. On endoscopy also the bulge in the nasopharynx. And still the diagnosis was uncertain. He consulted many places. Somebody was treating on the line of malignancy, it took multiple biopsies also, turned out to be negative. Somebody was treating on the line of malignant otitis. Yes, this is differential diagnosis. This is a difficult situation. It's always a difficult situation to differentiate between a malignant otitis and a nasopharyngeal malignancy with these extensions. Get a diffusion weighted MRI. This will differentiate one and all. On diffusion weighted, we got a diffusion weighted MRI at a high ADC value. The entire lesion at a high ADC value was classical of an infective etiology rather than a malignancy. And finally it turned out to be malignant otitis externa, which was treated on that line and we followed up on the basis of ESR and it did well. So MRI is the answer for most of the pathology to diagnose correctly or to differentially diagnose in the difficult situation. CT gives bony details, that's it. It has its limited value, it is important, it can be done fast, low cost, everything. But if you really want to go in the depth to diagnose and properly differentially diagnose, MRI is the answer. I'll show you a few more MRIs today to continue our discussion further.